Recording from the Sunshine City, St. Petersburg, Florida, overlooking beautiful Tampa Bay, this is the Sonography Lounge, sponsored by Gulfcoast Ultrasound Institute. This podcast is dedicated to medical professionals and patients around the world interested in diagnostic and interventional ultrasound. Our podcast will discuss everything ultrasound, from news, trends, career paths, new technology, and industry updates. Hosted by Lori Green and Trisha Rio of Gulfcoast Ultrasound Institute, they bring over 4 decades of experience in the ultrasound profession and are here to guide you through this journey. Now sit back, relax, and enjoy.
Hi, everyone, and welcome to the Sonography Lounge, sponsored by Gulfcoast Ultrasound, where we discuss all things ultrasound. I'm Trisha Rio, and today I'll be co-hosting the episode with Lori Green. Today, we're excited to have a special guest in our studio, the man, the myth, the legend, Dr. Jim Mateer. Dr. Mateer is an EM physician and clinical professor at the Medical College of Wisconsin and has served as our medical director since 1996. Welcome, Jim.
Well, thanks for inviting me to your podcast.
You're welcome.
Yes, you're welcome. We're so happy that you're here. In fact, we actually are involved with teaching an emergency medicine, critical care, and POCUS family medicine program this week, both intro and advanced level programs. So it's the perfect time to sit down and talk with you and help our listeners know a little bit more about you and our relationship over these nearly 30 years that we've been working together.
Been that long.
I
Wow.
know.
Yeah.
Isn't that crazy?
Oh, it's crazy.
Just kind of hit me.
Does that mean
back
we're
then.
getting old?
Yeah, unfortunately.
Not after what I saw today. You were sprier than most of those 20-something-year-olds, so.
That's true. So yeah, we're so excited to have you here and to finally get a chance to do a podcast with you. We've been wanting to do that for a while, so this was perfect timing to sit down and have a happy hour session so we could have a little drink. So cheers, everybody.
Cheers.
Woohoo!
Woohoo.
Good job this week so far. We still got 2 days left, but the major part of it's all done with.
And it's been going
Right?
great.
And it's been going great.
The
We had-
participants are excited. They've got lots of tools in their toolbox to take back and help improve their patient care and outcomes. So it's been a lot of fun and a lot of great learning going on.
Absolutely.
I think the participants, they get better and better every year in terms of what they're coming in with their skills set and their interest, and that's the thing that has surprised me somewhat.
Yeah.
So people are getting better over time.
Yeah.
Just coming into the course.
Absolutely, yeah. We always enjoy working with this group because they're so eager to learn and they really want to scan and spend the time involved. You know, they're not here because somebody else is sending them, and they
Right.
kind of have to learn something new. They want to learn it, and,
Very eager.
And the more they can learn, the better. And so we had some people leave us today because our advanced course starts tomorrow and they're not staying for the entire week, but the comments and, that we received were just amazing. Everybody's had a wonderful time and they were all fantastic to work with, so
Yeah, we're going to miss them.
yes. So with that, let's go ahead and get started and just talk a little bit with Dr. Mateer about when did emergency medicine ultrasound and POCUS actually begin in the U.S., because they were doing ultrasound for emergency medicine in Europe long before us, right? So,
Yeah, that's a great question. We had no idea that they were using ultrasound at the bedside. I wouldn't call it emergency medicine ultrasound because they didn't really have emergency medicine residency programs in Europe early on. But the clinicians were using it at the
Right.
bedside. Surgeons, internists, general practitioners, pediatricians. I didn't realize this until I had done this fellowship in Germany in 1991. And when I did that, by talking to them, I learned that, wow, they've been doing this since the early 80s, and that clinicians in Italy, Germany, Japan, for instance, a lot of them had portable machines, or they're more like desktop machines there that kind of sit on a desktop in their offices, and they would use them routinely to complement their exam. And I'm talking about like tens of thousands of these ultrasound machines out, in physician offices.
Wow.
Using them. And we had no clue here in the United States that physicians were using this, point of care, what we call now point of care ultrasound, as part of their clinical practice.
Right.
But we didn't really catch on to it in the United States until the late 80s. Around 1988 was when some of the first few articles started to filter out about talking about using ultrasound in the emergency department by emergency physicians for conditions like cardiac arrest or evaluating AAA or maybe ectopic and things like that. And some of the pioneers in that actually were, in Minneapolis at Hennepin County, Dave Plummer was one of the really early physicians to explore this. And he started lecturing and producing articles about using it particularly in cardiac situations. And still, Hennepin is kind of the leading edge in terms of the use of bedside echo for emergency and critical care things. And then, I'm thinking like a lot of the development of point of care ultrasound in the United States was in the Midwest, because emergency medicine started in the Midwest in the United States,
Yeah.
A lot of trends develop from the coast and go in, but not emergency medicine, okay? It started in the Midwest.
It was born out of a need.
And then it went out to the coast, actually. So ultrasound was the same way. And also in Pennsylvania, Michael Heller was one of the early ones in Pennsylvania, and Dietrich Yaley. They did some very early studies in the 88, or just kind of published their experience. So when I was in academics at the time, and when we started reading theirs, they're like, a light bulb went off, and we're like, man, this is something we should be doing. I mean, this makes so much sense. I mean, we should be getting this information early on as soon as we can. And that's when myself and our residency director at the time, Dave Olson, came down to Gulfcoast Ultrasound in 1989 to take our first course. And the first course we did was Intro Echo, which seems like maybe a more challenging way to start. But the reason we started with that was that we were in a trauma center, and we were seeing patients with gunshots and stab wounds to the chest. And there was some literature out there showing how important doing an echo early on is to identify cardiac injuries and how big of a difference it made in terms of the survival rate. And so we're like, we got to learn this.
Yeah, absolutely.
And then we followed that up a few months later by doing an intro to abdomen and intro to pelvic early OB ultrasound.
Do you remember how you found out about Gulfcoast way back when?
Wow, that's a good question.
I mean, there was no social media.
We were one of the very first to even offer ultrasound training. So
there was an internet.
Not a lot. There's no internet.
I know it's no. You're going way back. Okay, you're thinking there's probably no internet back there. Okay, but there was.
There was.
Yeah,
okay. Well, I remember my typewriter. And
we searched and we found out where educational courses were available.
Okay.
And we found some advertisement about Gulfcoast Ultrasound.
There you go.
And we're like, oh yeah, let's do that.
That's awesome.
Well, back then we did do a lot of mailing of brochures and
lots of mailing,
things like that. So it was a different way of marketing.
But the company was still a baby.
Well, yeah, I mean, Gulfcoast was started in 1985, so it was
the fourth or fifth year. I remember when we went to the original facility, there were pictures of each class of all the courses you did on like the back hallway.
Yep.
Oh,
and so it went back to 1985, and then our picture ended up there. Okay, our course. So
I still have all those pictures.
Oh, wow. Nice.
But we've done. I mean, we've been in business now 38 years, so we ran out of wall room. But and our classes have gotten considerably larger. But
we should revive that.
We used to make everybody
a digital photo book.
We used to make everybody get up in
Casey's
front of the room,
board.
take the pictures, and we've always had a good time with everyone. It's a family kind of environment with all of our participants, so we always have a good time. So yeah, And just to go back and look at the hairstyles alone is amazing. You know?
Wait, my hairstyle's been
you
the
haven't
same the whole
changed
time.
a whole lot, you know. But mine has changed quite a bit. A number of times.
I've seen the pictures.
The big hair, the short hair, the long hair,
It was even a different color at once, right?
Yeah. I even had the spiky, sassy thing going on one
Of course
time.
you did.
Yeah.
Don't worry, it'll come back.
I won't be going that way anymore.
Okay.
You know, I'm past that. But anyway.
All right.
We kind of got off a little bit, but that's okay, right?
All right. So you came to the courses. You came to Intro to Echo and then Intro to...
You're trying to get us back on track now?
We're working on it.
Kind of working on it, yeah.
Okay. So you took those 2 courses and...
Yeah.
What'd you do?
So
with that?
then, it's like the participants that come to the Emergency Medicine Critical Care course, the introductory course in particular, they're like, well, we're going to go back to our facility, and how do we get this going, and how do we use this? So we were, at the beginning of that whole curve, okay? Right. So we had to figure out how to do that. And so we, had to figure out how to get a machine that we could use, and then how we would use it. And so that's when as we were doing that, because we realized immediately how important this was and how much it changed our clinical management of patients to have that information right away. Mm-hmm. So we started using it right away, but then we met the resistance, okay?
Right.
So the resistance of medicine doesn't like to change, okay? And especially if a specialty or area of medicine perceives that it is encroaching on their area of practice, okay? So we met huge resistance. But fortunately, I was in an academic center, and our chairman, Joseph Darren, was very attuned to this, and he educated us that he said, it will all eventually be about credentialing. So eventually you're going to end up being at the credentialing committee in this hospital, and you need to document everything you do and save your numbers. And in the meantime, he said the safest pathway in an academic setting is to do things as a research project, because you can go through the Human Research Committee, get things approved, and we like that because we like doing research. So we set up clinical research studies on use of ultrasound in trauma and on ectopic pregnancy and training, what it takes to train. And so we did a number of studies like that took several years to do. So despite that, some of the departments that didn't want us to do it would fight us, but they couldn't because it was research. And
right.
So that's how we were able to soldier on through all that. There were a lot of things going on also outside of our institution, with regard to emergency ultrasound and point of care ultrasound as well, that helped move us along. But that's how we got through the initial part. And then the other big part of trying to do it early on was, well, when it's not established discipline, you have to somehow get the equipment. And as you know, ultrasound machines are not inexpensive.
Right.
So first we had to kind of beg, borrow, and steal. No, not steal, but, find old equipment laying around in the back room of the hospital that we could use, or convince manufacturers to provide us temporarily with equipment in order to do research. And eventually, actually, I ended up working part-time, moonlighting, okay, which is something that academic physicians don't usually do, and they aren't usually allowed to do. But because my department chairman knew that I would not be able to get funding to buy an ultrasound machine and to fund what we needed to do to get this program started, he said, yeah, okay, you can moonlight, in other words, work at an outside emergency department, not in the academic center, to bring in revenue, as long as it's not your salary, okay? So I would work 1 or 2 shifts at an outside emergency department, and they would write a check, for those services, and it would go into this fund that was our department fund, and that was my ultrasound fund that I used to buy the ultrasound machine, to actually finance the first fellowship in emergency medicine, to buy a recording equipment. I mean, because back in the day, I needed to have like a super VHS recorders and, software to like record, training exams and things like that. So that's how I funded really the program back in our academic institution between 1990 and really all the way through 1996, honestly, until we finally started billing for it. But yeah.
And this is why you're called the man, the myth, the legend. I mean, how many people would go through
that's what you said.
the lengths that you go through to bring ultrasound to the patients
Absolutely.
in your facility? That's incredible.
Yeah.
Well, there were others in academic medicine doing the same thing, okay? So I wasn't the only one. These were battles being fought at academic institutions throughout the United States.
And I feel like there's still some of this battle going on. Like you had the questions today during your training and credentialing lunchtime lecture.
Oh, yeah.
And you hear the same stories.
Yeah.
It's like, at what point is this just going to just lay this to rest and let's take what we have and what literature has proven to be a very useful modality and let us apply it and use it to improve patient care and outcomes?
Well, change in medicine can take a long time, even when it's something that is clearly documented as being beneficial. It still can take decades for it to be fully incorporated.
Yeah.
Right.
I mean, it's got to be a little bit frustrating to hear the same things going on today that you were dealing with.
It is, but it's less and less.
Right.
And I'm hearing fewer and fewer, and I'm having people tell me about how they had no problem and they were welcome to do it, and their hospital, their sonographers are like, "Oh, that's so great, you're going to be doing this."
Which is
that's
listen,
that's
sonographers, Point of Care Ultrasound is not a threat.
It's not a threat. That's actually a big thing to overcome, right?
Yeah.
But I mean, I think as well that having been working with Dr. Matier for so many years and growing, there are I now use Point of Care now so regularly, but I mean before it was bedside sonography, and there's been a lot of different terms used to describe it over the years. But at any rate, definitely in the beginning, everybody was dealing with the same barriers of, resistance to having emergency physicians doing, ultrasound in their department. And, it takes a lot of time for people to see the value in it. And I know a lot of times that people would say, well, you start with something that the other departments don't do, like ultrasound guided vascular access. And, over the years now, that's proven that if you use ultrasound guidance, it's much greater patient care and safety and less complications and all of that, those kind of things. So
well, the reason this developed is that because not to compete with other services, it was because the services were not being provided. Okay, so like at the institution I was at the time in 1980 and 1990, we did not have ultrasound available for a trauma patient to rule out pericardial tamponade, okay?
Right.
It just was not available. You could call up echocardiography and they just weren't available, okay?
Right.
And when we were worried about ectopic pregnancy, we'd call up and ask for that, and they'd be like, well, why don't you get a GYN consult? I'm like, wait a second, I'm the faculty member. You want me to call an intern on the OBGYN service to come down here and evaluate this patient?
Right.
That's not right. Well, then why don't you just hold the patient in the emergency department overnight until the sonographer's in the morning? So, those kind of situations, and it's different now, okay?
Right. But back then, that's what you were dealing with.
Made us realize that, wow, we just need to do this ourselves, like a lot of things in emergency medicine, because, you're the one there all the time. A lot of the procedures and things that we do in emergency medicine are things that are done in other specialties, but since we're the ones there, we needed to learn how to do them so we could do them immediately.
Well, and you need rapid answers.
Right.
Waiting for people to decide, okay, I guess I'll come do this.
Or even drive in, calling an on-call sonographer in to do an exam, and it's a life and death situation, and minutes count. So, you can get your answers right away and improve that patient's
I was talking
care.
about the resistance of specialties outside of emergency medicine, okay? But believe it or not, there was some resistance from within as well, okay?
Well, yeah.
So you'd think that, initially in emergency medicine, for instance, the American College of Emergency Physicians, ASEP, okay?
Right.
In 1990, they were one of the early accept, they thought, wow, okay, this might be something interesting. And they started a committee was formed, okay? Emergency Ultrasound Interest Group, I think it was called, or something, with ASEP. And that group actually created some educational courses. And they put these on nationally, about 4 or 5 courses. I was involved in some of them in St. Louis. It was fun, and there was a lot of interest. People showed up, emergency physicians showed up. They really wanted to learn about this. And those went on for a few years. And then also, in addition, the Society for Academic Emergency Medicine, which is SAEM, which is the academic group, which I was more involved in. Between 92 and 96, had a SAM ultrasound interest group, which became a task force in 1992. I was the chairman of that committee. And the task was to develop a curriculum for ultrasound education. So our group developed this, and we published this model curriculum. Yeah. And in fact, then we developed an educational course that we put on at the SAM annual meeting. And I think the first one was in 93 or 94, probably 94. And it was very successful, and people wanted it again. But what happened in both ASEP and SAM is that the leadership rotates.
Yeah.
And these are physicians, and some of them are residency directors. And some of the physicians that are in leadership roles are like, oh man, this is going to make it difficult. We've got a whole curriculum set up for our residents. We got that fine-tuned.
There it is.
What, we're going to have to add ultrasound to this? This is going to be, messing up our whole thing. So actually, within our own specialty societies, there was resistance then, around 93 through 96, and they decided, no, we don't want you doing these educational courses. And in fact, that money that I made, by moonlighting, I'm like, well, you don't want us to do it at SAM? I'll tell you what, there's a lot of interest in this. I'll just do a course wherever the national meeting is, and I'll find a facility to do it close to the conference center. And there are tons of people that wanted to do it. I mean, we, had to, sorry, we're full, okay?
Yeah.
And the SAM leadership didn't like that. In fact, believe this or not, I got a couple letters from them threatening to sue me.
Oh my gosh.
They didn't want me to do it, okay? I think it was to protect their whole idea of their, what they had to teach their residents and things like that. But their thing was that I was doing this course, and I called it Emergency Medicine Ultrasound Training, based on the SAM Ultrasound Task Force guidelines, okay? Which were published, okay?
Right.
So, I wasn't saying that it was sponsored by SAM, but they didn't like that, and they said, no, it can't. You cannot have the initials SAM anywhere in your educational syllabus or your advertising or whatever. I'm like, this really affected me, because from the standpoint of being an educator and having a lot of academic physicians really wanting to learn this and teach their residents, to have like others, like within my own specialty, fighting it. I mean, I can understand other specialties fighting me, but
not your own.
My own, okay? That really affected me, and I think it was sometime around that I started to talk to you, Lori, about, hey, I've got this educational material. We created this whole course.
We've got the model curriculum.
We've got a demand. But, what about doing it in the private sector? Because, there's a lot of practicing physicians that want to learn this. So, so that, maybe you have recollections about how that went, when we were first starting to talk about doing a emergency medicine ultrasound course at Gulfcoast. Well,
I remember you reaching out to me, and I definitely remember you and Dr. Olson coming to our courses. We had so much fun working with you guys, and it was just so amazing to listen to how you were going to use it, and it was being so innovative and how that was going to improve patient care. But there also was some challenges of dealing with different departments and so forth that were not going to be supportive of you, but we were excited to work with you, and you already had the model curriculum, so it made sense to just develop this course and utilize the model curriculum. I mean, that's what people want to know. I mean, you've developed these courses, you didn't just pick willy-nilly, I'm going to do this or that. You have guidelines that you're going by, and that's what we do with all of our courses. Is there's published ultrasound guidelines, and we teach our courses accordingly to make sure that you are learning what you need to know and what's been, documented and the research shows is effective and improves patient care. So that was awesome. And so we just got together and we started talking about it and putting it together and deciding how to get the hands-on going. And it's grown tremendously over the years. The guidelines have changed, obviously. And
Gulfcoast ultrasound facility has grown and changed over time.
Yes, significantly. So, the whole, who would ever think, you don't, when you start a business, you're like, oh, I'm going to do just this, and then the next thing technology changes and attitudes change, and, who would ever think that virtually every specialty practice group now is doing ultrasound, and it's not just being done by sonographers in departments, but, it's being done at bedside, and people are benefiting from it. But
when Gulfcoast started, you were doing education primarily for sonographers, right?
Yes, right.
So were you doing educational seminars for vascular surgeons before you did the emergency medicine?
Yeah.
Because they started before us, okay?
Right, yes.
And they actually had their battles with, conventional imaging specialists that they had to fight in order to, be able to do that as well. So I know that.
Yeah.
But you were doing that,
Yeah, when we started out, we just were really, our market really was geared towards the sonographers because there really wasn't any long-term ultrasound programs out there. So people were pretty much learning on the job, x-ray techs being cross-trained and so forth. And so when we first started doing our courses over time, over a few years, physicians started coming, and we weren't even marketing to physicians.
Yeah.
And we're like, wow, this is crazy. And and then they would come up and say, why don't you get AMA Cat 1 credit? We love you. Of course, this is amazing, and we, you need to really, if you do that, more physicians will want to come, and they can integrate that into their clinical practice. So that's how that started. And you're right, vascular was the first, probably vascular and cardiac actually were the two specialties where we started seeing a lot more physicians attending.
Right.
And then as we offered the emergency medicine over time, and we started our first emergency medicine course was 1995. I was thinking it was 94, but I think the ACEP guidelines were you had the model curriculum, but then there was ACEP guidelines that were published.
I'm not sure when those came out.
I think it was 94, but it kind of tied right in with the model curriculum, and then subsequently the ACEP guidelines came out, and there was a tremendous amount of interest. Do you remember that? We had classes were full.
There still is.
They still are, but it just was, you never know when you start a new course. Like we're used to being the innovators and always having the technology and teaching cutting edge, aspects of ultrasound that others aren't offering. And we know that when we do it, that they're going to be small classes. It takes time for people to adapt to change, like you said. And so it usually takes, 3 to 5 years before you really start seeing full classes in new techniques. But that didn't happen in the emergency medicine. I mean, the first one might have been relatively small, but I just went back and looked at all my stats before we did this podcast, and almost every class was full capacity. So there definitely was a need. There was an interest at that time, and it's just grown exponentially because now it's in residency programs have integrated it into their curriculum.
So at this point, what would your estimate be of what percentage of the courses, of the live courses, are attended by physicians or mid-levels versus attended by sonographers?
It's about 60% physicians and other mid-level
physicians
providers.
The clinicians are in the majority now.
Yeah.
Yes.
Wow.
Yeah.
That's amazing.
I know. Well, I mean, if you think about it, the way that ultrasound's being utilized now is there's a lot more point of care bedside sonography being performed and being done by.
So it started with echocardiography in terms of physician-attended courses, then vascular, then emergency medicine. And now you have musculoskeletal, anesthesia.
Yeah.
What other? You have primary care.
Right.
Peripheral nerve.
You have nerve block. Yeah.
Right.
What?
Nerve blocks
Is there
and
something I'm
just
missing?
peripheral nerve.
Still
ultrasound.
vascular
Yep.
program.
We still offer all of those,
Yeah.
and we
Yeah.
still have, obviously, people need to learn all new techniques, but definitely our point of care applications, MSK, emergency medicine, those type, family medicine is growing.
Family medicine definitely growing.
Definitely growing. It's taken them a little longer to catch on. I think they've wanted to do it, but there's the financial end of it and the training, and then also getting the support of their society to back them up. And they're seeing now, like in AFP, their meetings are now incorporating more ultrasound lectures. And they now have ultrasound practice guidelines, AFP does, that they modeled after ASEV's ultrasound practice guidelines. There's a couple little differences, but essentially they are pretty much the same.
Well, and I think that's because it's such a diverse practice.
Right.
You can be in urban and where you're going to only use select things, but then you have your rural locations, your austere locations, and they need to have more of the critical care applications at their fingertips so that they can take care of those patients without having to send them an hour and a half for a scan.
Right.
You might not make it,
Right.
And we have 5 people here this week who are doing our family medicine track, and all 5 of them come from different backgrounds and different practices, and they're going to utilize ultrasound in a different way. And it's just such a diverse field.
It is such a diverse.
I mean, emergency medicine physicians are all utilizing it in the same way. And then you talk to them and you're like, wow, like the way you're going to use it and the way you're going to use it and the way you're going to use it is so different. It's exciting.
I'm really glad to see the primary care physician family practice finally that part of it starting to increase in interest, because early on when we developed the training program for emergency medicine, there were a couple family practice physicians, academics, that saw the relevance of this, and they had tried to develop this into their curriculum, and it just never really caught on. And that's been a really slow process for family practice, for instance, the specialty of family practice, to start incorporating that, and some of them incorporating into their residency programs. And we've gone and done some on-sites now at family practice residency programs that want to, that are incorporating that into their residency training and things like that. So I'm glad that's catching on, because it's so relevant. And as I was saying, we're talking about the early 80s and mid 80s when, the general practitioners and family practice primary care doctors in Europe were using this at the bedside just to, help them with evaluating their patients, improving their clinical diagnosis.
Well, I mean, I think that part of the, family practice coming around now is a lot of that's due to technological advances and the miniaturization of the ultrasound equipment, because they can utilize that in their private practice, a handheld system, at least, if nothing else, get a yes/no answer whether they need to send them on for a more formal ultrasound exam if they want to do that, or do it themselves. And initially it's like, oh gosh, I got to spend this amount of money on equipment. I got to go to a training program. I got to learn how to do that. See all of my patients. That's a little overwhelming. But now, you can get some pretty decent ultrasound systems that are affordable.
we do have to give credit to the ultrasound companies and the technologists that work there that have continued to develop the ultrasound equipment to make it, the images. I sometimes tell people, hey, the images are now, approaching that of an MRI, okay? When you have a high-frequency probe and you're, sometimes better, actually, when you're talking about the shoulder and some MSK things, it's better than an MRI, so... and yes, the equipment's much easier to use. You don't have to, do as much knombology, in terms of to get a perfect image.
And they're building in the AI, so some of it's like guiding
That
you.
part of it scares me. I don't know.
Yeah, we are kind of moving, but
No, but
next thing you know, we'll be
it's
tracking.
helpful. I mean, it's helpful because I see novice learners who are utilizing the tool and how excited they get that, the Echo News system, the Cosmos, for instance, was auto-grading their image and telling them, you have a great image. They're like, it's telling me I have a great image. I have a great image. And that's exciting, as somebody who's new to ultrasound and you're learning. And then it's labeling stuff. So if they're questioning something like, oh yeah, that was the right ventricle. Okay, I was in the right spot. I just think that that's exciting and it provides feedback. And for a learner who's leaving our course and going back to a rural environment, maybe doesn't have a lot of support, people that they can turn to and say, am I doing this right? What do you think of this? They don't have anybody to bounce it off of. It's nice that these systems have all these built-in tutorials and all this information that they can just, it's more resources.
Yeah. I was kind of kidding about the AI scares me, but, sometimes, well,
Maybe a
but,
little.
sometimes young people approach me that are interested in healthcare and they'll say, what can I do? And I'll encourage them to think about going into sonography or echocardiography because, despite the advances in technology, I don't think the sonographer is going to be replaced, okay? Because there's an infinite number of views with an ultrasound exam, and somebody needs to understand how to do that.
Yep.
And I don't think that a robot is going to be able to do that because there's also an infinite number of differences between every human and patient in terms of how to obtain those images. So,
Well, for example, I had a model today. We were doing our focused abdomen assessments, and she's sitting here telling me, okay, when I was 7 years old, I tripped over a toy box, and I ruptured my left lobe of my liver, and they had to emergently remove it. And I was like, oh, wow, I've never heard of that happening. Okay. And so I start scanning her, and I'm like, your kidney's in a different place than it normally is, and your renal veins in a different place than it normally is. And she's like, yeah, and they're not sure if I have my gallbladder or not. And I was looking in the place where the gallbladder should live, and I'm like, well, I don't see a gallbladder here, but let me follow the biliary tree. Let me see if I can find at least a neck, and then see if I can find and it was down by her right hip. It was down by her appendix.
Wow.
Would AI be able to find that? No. No, they would not. So, yes, I'm not going anywhere.
I think that's really an important point to mention because there are sonographers who feel threatened not only by AI and technology taking over, but more so I think they feel threatened that physicians and mid-level providers are also learning how to do ultrasound, and it's being done in these various departments, and they feel like their job's going to be, obsolete. But it definitely is not the case. I mean, we always try to, with any of the sonographers that we interact with, to help them to understand the benefits of being able to get that quality of care at the bedside, to get the important information known, to get them to treatment or whatever the management should be quicker, and to also for patient safety. I mean, as you've talked about this before. I believe it's like 1 CT is equivalent to the radiation you get from 500 chest X-rays. Is that right?
The numbers are going down.
Are they going down?
Improved.
They're improving.
Maybe it's 250 chest X-rays.
It's
now.
a lot of radiation, right?
Yeah,
so,
it is.
And you think about all the people who have kidney stones and go to an ER, and it's probably better now because with EMR, there's probably able to track what people have had and where they've had it done at. But before, you go in. I mean, people have kidney stones. They're coming in right and left, and CT, when they could be scanning them with ultrasound.
It's
and
more
so
cost effective
radiation.
and it's safer.
Yeah.
Okay.
So we don't
it doesn't
cause
always
them.
give you the answer, but many times it does. So.
Great place to start.
So why not, have that capability and be able to get those yes/no answers, and then if they do need to have something that's more comprehensive, then they go to those specific departments, radiology, cardiology, wherever, to get those. So I really don't see that taking place.
And point of care ultrasound doesn't. I don't see it threatening. Sonographers that are doing conventional ultrasound because you find things. Okay, the clinician is using it at the bedside for a specific question that they want answered. Okay, and they will either get that answer or they won't. If they don't get the answer, then they still need to do some type of imaging study, possibly.
Right.
And also sometimes when they're looking for the issue that they're concerned about, they find something else, and that leads to them, hey, I need to get a complete ultrasound or a complete this or that for that patient. So
Right.
it doesn't end up replacing ultrasound or threatening their job. So
Right.
And I find it a little confusing that I hear the same group talk about how they're spread too thin, how they're short-staffed, how they're overworked, how they need to have guidelines for how many exams they should be doing in a day, and then turn around and say, oh, nobody else can do ultrasound, only we can do ultrasound. We don't need anybody to help us. It's like, you can't have both. Like, either it's one or the other. So if you are overworked, if your department is short-staffed, if you're constantly being called in for things, wouldn't it be nice to have a group of physicians in your emergency room who are capable of utilizing ultrasound to make clinical decisions and not have to rely on you driving from your house at 2 o'clock in the morning to come do a study?
Right.
Like, who wouldn't want that for a patient?
Right. And know that the patient's going to get, the appropriate management and treatment a lot quicker than having to wait for you to.
well, that's one way we try to sell it when we're
Right.
trying to start an ultrasound program. But let's get back to
Sure.
ultrasound in emergency medicine. We kind of stopped, I think, at where we were starting the emergency medicine ultrasound program at
Right.
Gulfcoast. And, I was talking about how towards, to around 95, 96, I was really getting disenchanted with the fact that I wasn't getting support. And in fact, that led to me leaving academics when I got a job offer from some friends of mine who formerly were in academics. It was closer to my home, and they basically recruited me. And part of it was that, I was disappointed about really not having the support I felt I needed to pursue what I was really interested in. But I also felt secure doing that because we were doing the Gulfcoast ultrasound course, and I was able to continue in my academic role at the medical college part-time to do some teaching, but I knew that I'd be able to teach at Gulfcoast because I really enjoyed teaching ultrasound. And subsequently, ACEP and eventually SAM came back to supporting ultrasound. So
Right.
sometime after that, there were a number of leaders that pushed this forward after I left academics, okay? For instance, at ACEP, Vivek Tayal, I remember, he was somebody who was involved in the ACEP working group for ultrasound, and he really did a lot of work on echocardiography. He had good support at his academic institution. He wrote one of the first chapters in the book, Emergency Ultrasound, on echocardiography, and did a great job with that. And so then ACEP group were able to push forward a lot of the educational criteria and guidelines for education. And then SAM took a lot longer. I mean, they took like 10 or 15 years to finally come back to it for some reason. I don't know why, but they eventually came back to it. And there were other, national organizations, for instance, like AIUM. So, thanks. You're going to get me a little something
A little
to
more wine.
clear my throat.
Clear
Thank
your
you.
throat. I don't have any of
Sorry,
that water.
Kind of fighting a cold here.
Who wants water right now? Here you go.
Fighting a
for
cold
the heart,
here.
you know.
Sorry. But also, we do a lot of talking at this course.
We do. We've been talking nonstop, right?
So you talk during your lectures, and then you do a lot of talking during the hands.
Yeah,
on.
exactly. We're all
You can wear out
have
your voice
laryngitis
after
by
a
the
while,
end of
right?
the week, right?
Yeah.
So it's like nonstop talking.
But AIUM, the American Institute of Ultrasound and Medicine, was also a society that supports ultrasound for sonographers and physicians back then. And I was a member of that, from probably 91 or 92 on. And they didn't really understand, the concept of emergency physicians or clinicians doing it at the bedside unless you were an obstetrician or something like that. Okay? But, so initially they didn't support that. In fact, their working groups on developing educational criteria, their working group at the time was comprised of 3 radiologists and an academic OB/GYN doctor or something like that, okay? And when they caught on to that we were developing this model curriculum and we were publishing it for emergency medicine, they put out their criteria for what you needed to be to educate somebody for a physician to use ultrasound, okay? And it was like, okay, you need 100 hours of CME, and you need like a minimum of 350 exams or something like that. And if you were in a specialty that used ultrasound in one or more than one organ system, then you needed more, like at least 500, okay? So those were basically the criteria that were out there, and I'm like, well, even though emergency medicine is we were training residents and other physicians, so we knew what it took for us to do limited ultrasounds. It was nowhere near that, okay, for asking specific questions, right? Okay. Well, so, but for me to basically get credentialing in my own institution, I made sure that I met all those criteria. So I had like 800 exams and who knows, a couple 100 hours of CME before I finally got my credentialing, approved at my own institution, like in 1993 or something like that. And but there were other physicians. I went on a little bit of tangent there, but other physicians at AIUM that persisted, like David Boehner. I don't know how he did it, because I was so upset that they put up this wall, for physicians that were trying to do point of care ultrasound by setting the bar so high that most of us wouldn't be able to do it.
Oh, you know him. He just runs right through walls.
David Boehner, he persisted.
He's amazing.
And he continued, and he finally, convinced them that, hey, point of care ultrasound is a thing, and AIUM warmed up, and so they're a supportive organization now. So.
Absolutely, they are. Right? They have a whole emergency medicine point of care community.
Right.
And I know David is a key member of that
Yeah.
community there.
And so the emergency medicine, the initial EM course we did evolved, and maybe, Lori, you can talk about that a little bit, about how it evolved over the years and what we do now and what's available now in terms of our products at Gulfcoast for emergency critical care ultrasound and point of care ultrasound.
Yeah. Well, like I said, we offered our first intro emergency medicine course in 1995, and it was so successful that we continued offering it, and we then added on with all the changes, and as new applications with the ACEP, they had their core applications and they had their advanced applications as time went on. So as those guidelines were expanded and developed, we added on our advanced emergency medicine class in 2002. And then we decided, well, we really need to address the needs of critical care, so we offered a dedicated critical care ultrasound course separate from the emergency medicine course for quite some time. We started that in 2007. We've subsequently now have kind of merged those programs together, and we have different tracks now from intro emergency medicine, and then those who don't want the GYN, they don't have to come on day one. They can start on day two in the critical care track, and then those covers the applications that apply to both emergency medicine and critical care. And then as time has changed, we've had our educational products have expanded as well, and with online activities. And so we now offer our online courses that are basically the same lectures that you would get if you come here to a live traditional course, and then you can do a hands-on only workshop. So we have what we call our point of care scan only workshops, which are blended, and we started doing those in 2011, and those have grown significantly. A number of times we offer them. We do those twice a year, but one point of care scan only workshop has 8 tracks to it. So we're actually doing 8 courses in one program.
That was when I came on board, was 2011, and I was like,
said,
what?
well, this one's a little complicated to
You didn't know what you signed up for, huh?
Well, I mean, I didn't know point of care ultrasound. I didn't know emergency medicine. Like, it was a foreign language. They're talking about all these applications, and I was like, what? But wow.
Yeah. So we do that. So if you can, we do the traditional format lectures, hands-on program twice a year. It's typically January, February timeframe, and then in September. And then we do our point of care scan only workshops, which is the blended format. You do your online course before coming to us, and you just scan for 2 days. You get so much hands-on.
I like teaching those courses.
Yeah,
there's
they're
so
a lot
much
of fun.
The people that participate really want to improve their hands-on exams and their skills, and
It's 16 hours of hands-on.
Yeah, I mean, you only want. We have some that are 1 day and some that are 2. So if you're doing the whole ER course, you're going to do 2 days. But some people just want vascular access. They come in for 1 day.
And you're working with a smaller group, and so you get to know more specifically what the individual needs of that person are,
Right.
and you can refine your education to that. Your education on how to improve their ultrasound skills to that individual. Those work really well.
Right. Yeah.
They're fun.
And we put a lot of work into the details of it that you won't see in other entities. Even today, I was in the middle of moving people around and making some adjustments for people who wanted something, specific or whatever. And one of the girls goes, it's mind-boggling what you do here to make everything work so that everybody, no matter what their specialty is, they're getting what they need for that particular specialty practice. And we group people together accordingly. So when they're asking questions, everybody in that group, they want that same answer to that question. Yeah. You don't have somebody from here or there. They're not just throwing a bunch of people together. We really pay a lot of attention to it. So this has definitely been a specialty that has grown exponentially over the years. And so you have to grow with it. And so the point of care scan only is definitely 8 different tracks. And when you tell people that, when they don't, they've come on day 1, we're like, okay, don't worry. We have 8 different courses going on here simultaneously, but we have spent a lot of time making sure that you're getting exactly what you signed up for. So don't worry about it.
Just have to go where we tell you to go.
Yeah.
That's right. Don't wander. Okay?
A lesson that I learned many years ago. Just do what Lori tells you to do.
Everything will be
just
okay.
kidding.
No,
everything's going to be all right. There's a song about that, right?
Don't mess up the gears, okay? It's finely honed, okay? That's
right. We even started a dedicated trauma and acute care sonography course in 2015. And we did that for 2 consecutive years, but then we decided, well, that's going to be better suited as a blended program, and we merged that into the point of care scan only as a blended.
Sure.
So that's a track, one of the 8 tracks,
And
So
then pre-hospital came along.
And pre-hospital, we're now doing pre-hospital
I think that's going to be a growing important area. I mean, EMS, whatever works in a clinical setting, that physicians initially do some type of procedure, okay, in emergency medicine or other areas, okay? And when it is really something that is important and it works well, it kind of ends up going to the mid-levels are doing it, and then the nurses are doing it, and then the pre-hospital care providers are doing that thing. When it's that strong of a procedure that really is helpful for the patient, that's kind of the way things go. So,
right.
I was a medical director of our flight program for almost 10 years while we were there, and we started to think about using it in the helicopter course. Okay. Right. And that was, I think, one of the first pre-hospital applications of it. A number of academic centers and hospital centers have helicopter programs. So that was, I think, one of the first areas to incorporate point of care ultrasound. As you'd fly out, you'd have critical care patients, whatever you need to use that. But now it's, like using ultrasound to start an IV is very common for nurses and IV teams to do.
Right.
And now that, and also looking for life-threatening things that paramedics can treat in the field.
Right.
They're starting to use that in the field so that they can identify what's going on before the patient gets to the hospital, or actually use that to identify and treat it. I mean, they do things like pericardiocentesis, for instance, or things that paramedics are trained to do, but, unless you can confirm that that's what's going on, you're kind of just winging it, right? So that was just an example. But, so now that's the direction that it's going, and it'll be interesting to see how widely that is incorporated into EMS systems that,
Right.
paramedic systems and things like that.
Right.
Yeah, they're an excited bunch. We had 4 of them here this week, and they've been amazing learners. And
Oh, yeah.
so much
They're
fun to
doing a
work with.
great job.
Yeah.
I'm surprised at how well their skills have
Yeah.
progressed.
It's interesting, like with doing EMS World and some of these trade shows with the pre-hospital guys, like the stories that they're coming out with, it's like the energy is crazy. I remember this past year there was a girl came up to me and she was saying that they would have called this person code, but she has just started like using the ultrasound system and came up and like checked, and there was still cardiac function, and had it not been for that training that she underwent, that person would not have been around. And so she was just like so excited, and seeing the tracks and stuff now like coming out in pre-hospital is awesome.
You have to experience EMS to realize how much diversity there is out there in terms of the situation, okay? In the emergency department, we think, and we call it controlled chaos, okay?
Yeah.
Because it's chaos, but,
Yeah.
it's in our structure, it's in our building, it's on our court, okay?
Right.
But EMS is on somebody else's court,
Right.
okay? And there are so many variables there. So there's definitely some crazy scenarios out there that EMS providers adapt to. So
Oh, my
Yeah.
goodness.
yeah.
Absolutely.
They have my ultimate
Yeah,
respect.
it's definitely an area where they need to integrate the use of ultrasound, the handheld, for
Yeah,
different
so it'll be fun to see how that
applications.
goes.
It will.
Yeah.
Yeah. Look at where we've come all these years. I would have never thought we would be where we're at now when I first got into ultrasound, and with all of the changes in technology and utilizing it for different applications, especially in the point of care aspects. I mean, even in the next 5 years, I think we're going to see a tremendous change in how and when it's being used, but they all need education, right?
The
We
era
can
of
do it.
COVID opened the door. I'm telling you. It's like somebody took the lid off the box and everybody said, "Oh, ultrasound." Yeah. So here we are.
I mean, ultrasound is definitely here to stay.
Yeah, it's not going
And,
anywhere.
We were doing the free stream of our lung ultrasound program during like the start of COVID. We had 20,000 people like tune in worldwide.
To learn how to
Yeah.
do lung
Wow.
ultrasound.
Right.
We did it
Yeah.
free, like so that everybody could have access to the education. But
Yep.
it was amazing seeing those
Right.
numbers.
Way to help out with the pandemic.
Right,
Way to
and
go
oh
there.
man, you
Wow.
wouldn't believe the people that were sending us, emails saying, "Oh, thank you so much for doing this. We need this so badly right now, and we had no idea how to do it." And
Yeah.
Yeah.
and so that was our contribution to the
Awesome.
pandemic. But yeah. I mean, there's certain techniques that are not that difficult to learn, and if you
Well,
have the
listen.
resources.
At the end of the day, the education needed to be out there, and
Yep.
we weren't going to let a pandemic stop us from spreading it. So if we can't have them come and join us here, we were going to just give it to them for free.
Heck yeah.
Like, here you go. Take it and remember us later.
That's right.
So.
Well, I think this has been a great discussion.
been a lot of fun.
And we're so happy to finally get you onto our podcast and let everybody know about you as our medical director and all the contributions that you've made into the ultrasound and emergency medicine practices. And our company has been significant contributions and helped us get to where we are today. And we still continue talking with him and getting his feedback on different aspects of things that we think we want to change, and it's been very valuable, so we appreciate that.
Well, I really enjoyed this podcast. It's my first podcast.
Has it?
And yeah, so what I've learned about podcasts is that you get to sit in here and talk about things you are excited about,
Yeah.
and you get to have a glass of wine while you're doing it.
That's right, especially
Well-
you're doing a happy hour one for this for sure.
Maybe not during the working day, but this is after hours. It's like,
Yeah.
what time is it? It's dark outside. It's 6:45
right.
p.m.
So, yeah.
Eastern Standard Time.
Well, these are our favorite ones because we do get to have a glass
And
of
mind you, we've all been here since way
6:30 this morning.
way early this morning.
Yes.
We deserve this.
Yeah, absolutely. So,
Podcasts are a lot of fun. We both were a little like, when we first started doing it, but
yeah, we
it's
were a
been
little nervous, but we
been a
we
lot of
enjoy
fun.
doing it.
I've been like slowly sneaking in more and more technology.
Yes,
and
he
videos
does. And we're like,
Yeah.
what? You're doing video? Oh, no. But
They're taking it in stride.
we are,
been a lot of
change. We are adapting to change. That's what
It's
we
funny. I
have
tell
to
my friends, I host a podcast. They're like, what? I'm like, I know. I co-host a podcast. Like, This is
We just hit
crazy.
13,000 subscribers.
We
Oh
did.
my
So it's
gosh,
Yay,
that's
awesome.
amazing.
That's
Well,
great.
yeah, our listeners are awesome.
Right, and we haven't been doing it that long, just a little over a year. So,
Yeah.
so thank you all to our listeners for joining us and subscribing, because we do appreciate you, and we hope that you're learning a lot,
Laughing a little.
and just enjoying the information that we're sharing with you. So,
Yeah.
so thank you, Dr. Mateer, for joining us.
Yes, thank you.
Thank you to our
Thanks
listeners
for inviting me.
joining us.
Yeah. All right.
And
well,
if you usually do the tagline.
happy scanning. No, really. If you guys want to suggest content, we're looking for some new episodes, so you can always email us. What's the email address, Casey? I can't remember. Sonography Lounge.
gmail.com.
There it is. Sonography Lounge.
Yeah, they're digging
gmail.com.
pretty deep right now for their podcast content. Okay, they asked me to talk.
That is not
So
true.
please
That
come
is
up.
not
We've
Please
asked
come
you
up
how
with
many
some
times?
additional ideas now.
We've been inviting him for a while.
A while.
Now. And finally, well, you're here and you're doing it.
I had to strike a deal. We promise we won't record your lectures if you come and do a podcast.
Right.
I like to walk around while I talk, okay? And when you record the lectures, I have to stand in one place.
I know.
So, yes.
But you got what you wanted, and
I
we
don't
got
want a
what we wanted.
DVT, okay?
Yeah. No. That's right.
All right.
Yeah. Well,
Okay.
again, thank
Very
you to our
good, yeah.
listeners,
Yes.
and thank you, Dr. Mateer, for joining
It was fun.
us.
Thanks.
Thank you,
Enjoyed it.
Casey,
Casey,
always
yeah.
our amazing soundboard mixologist who makes us sound awesome and like we know what we're doing.
And it edits out all our bloopers.
All right, you guys. Well, enjoy, and be sure to visit gcus.com for free resources, more info on our training resources that you can purchase, classes that are upcoming, and submit those ideas for podcasts, and we'll be sure to get them on air.
Absolutely.
All right. Well,
Okay.
happy scanning.
Happy scanning, everybody.
Thanks for listening to the Sonography Lounge. Don't forget, if you like this episode, please subscribe and leave us a review on iTunes, Spotify, or wherever you get your podcasts. You can also find us on Instagram at Sonography Lounge and Twitter at SonographyLNG. If you have any questions, comments, or topic suggestions, feel free to send an email to us at sonographylounge@gmail.com. Have a great week, and scan, scan, scan.